Okay, good morning and welcome everybody to our Health to Hold community resource webinar series hosted by the Ocean Monmouth Health Alliance. My name is Jenna Sistad and I am the project manager for the Alliance. And if you're not familiar with who we are a Department of Health funded initiative. The funding comes through the Visiting Nurse Association's Children and Family Health Institute. We are the region's Cancer and Chronic Disease Prevention Coalition, and we work with many partners throughout the region to promote wonderful services that are offered to our families. We host this series every month, and we ask different coalition partners to highlight with us the Health Awareness Month. For September, it happens to be Ovarian and Prostate Cancer Awareness Month. So today we have Dr. Loda from the VNA's Community Health Centers of Central Jersey here with us to take us through some education on prostate and ovarian cancer, as well as to talk with us about what the VNA CHCs offer as far as services and programs. So we thank you for being with us today. We ask to keep questions either in the chat box or hold them till the end. Dr. Loda will do a Q&A with us. And also, if you can, keep yourself muted and please put your name and contact information into the chat box so we know who's here with us today. Thank you all for being present, and thank you, Dr. Loda, for doing this with us. Welcome, and the floor is yours.
Good morning, everybody. Thank you, Jenna, for that little introduction. Like Jenna said, my name is Yasha Loda. I am a second-year family physician resident at the VNA under Rutgers Robert Wood Johnson, and I hope everybody's having a great morning. As we all know, September is cancer awareness for prostate and ovarian cancer. So we will be talking a little bit about what prostate and ovarian cancer is, what to look out for, what the current screening guidelines are, and how to move forward with that. So this is the VNA's mission statement. We provide comprehensive care for our communities, regardless of insurance. So we do accept patients who are uninsured, underinsured, including insured patients. Our dedicated team of healthcare professionals is committed to providing high-quality, patient-centered healthcare to communities. We do see patients of all ages, including neonates, adolescents, toddlers, pregnant patients, and also our seniors. At the VNA, we make quality healthcare affordable so you can stay healthy and live better. The VNA is located at 4 sites, including Freehold, which is where I'm primarily located, Red Bank, Keyport, and Asbury Park. The VNA offers both in-person and telehealth visits. In the in-person setting, we do have physicians, and we also have nurse practitioners, so you can see both. And same is available during our telehealth visits as well. At the VNA, we provide SEED visits. SEED is essentially for cancer screening. It's cancer education and early detection. We also offer a sliding scale payment model. So this is based on a person's annual income and also the size of the family. And we also provide discount coupons for medications for our uninsured or underinsured patients. So these are a few examples. We have GoodRx coupons that will be available to you after visits are ended. And there's also specialized discount coupons for our insured patients. There's also something called coordinated care. This is usually available to our uninsured patients who need assistance with medications. So physicians or nurse practitioners will send you the medication, and the companies will reach out to our uninsured patients and assist them with getting these medications at a discounted price. For patients who are uninsured or have difficulties with transportation, we also provide Uber and Lyft coupons, so it's not difficult for them to access care at any of these 4 sites. All of our sites have free parking as well, so that would make it convenient for those who have their own transportation. Hours of operation, so the VNA functions Monday through Friday, 9 a.m. to 5 p.m. And we also have a call center that is available 24 hours for those who have any emergency requests, but also need to schedule appointments. But of course, in situation where you have a true medical emergency, we advise that you call 911 instead of calling the call center. One of the locations every month is open on Saturdays. The work hours are from 8:30 a.m. to 5 p.m. and the first appointment is at 8:40. So first Saturday of the month, we have Asbury Park. Second Saturday of the month is Freehold. Third Saturday is Keyport, and the fourth Saturday is at Red Bank. So these are some of the services that are offered at the Freehold Family Health Center. So like I mentioned, we do provide primary care to all age groups, including neonates, toddlers, infants, adolescents, prenatal care, and also our geriatric patients. We have dental care. We have a chiropractor that's available at least 3 times a week. A chiropractor and the sports medicine doctors, they do therapeutic injections, they do trigger point injections. They also perform maneuvers for your musculoskeletal problems. We also have an OB-GYN available for your prenatal care. It's not just limited to prenatal care. We also provide counseling on contraception, pre-pregnancy care, and also postpartum care. We also have a geriatrician at our Freehold Family Health Center that is specifically designed to provide care for our geriatric population. Some services offered at other locations are LGBTQ care, HIV care. We also provide behavioral health at all of our locations. So what do we do here as family physicians at the Freehold Family Health Center? So like I mentioned, we do perform well child visits, well adult visits, women's health visits. So we usually screen patients for depression, any anxiety issues, interpartner violence. We also look at vaccine records and we perform vaccinations for all age groups. We do cancer screenings at seed visits. So seed visits are specifically designed for cancer screening. These can be done at any amount of time during the month. So some of the screenings that we offer at our location is colon cancer screening, cervical cancer screening, breast cancer screening, and then, like I said, we will talk about prostate and ovarian cancer as well. We also perform school and sports physicals. And I also mentioned that we do detailed women's health services, including prenatal care, contraception counseling, postmenopausal care. And if there is something that is beyond our scope of practice, then we also provide referrals to further specialists. And we also take care of common conditions like blood pressure, diabetes, thyroid management. We prescribe medication. We do surveillance, monitoring, and treatment as well. So let's get right into it. What is prostate cancer? It is one of the most common non-skin malignancies in men in the US. In 2023, about 288,000 new diagnoses of prostate cancers, and there were about 35,000 deaths in the US alone. An average individual has a lifetime risk of 11% of getting diagnosed with prostate cancer, but the overall risk of dying from prostate cancer is low. It's fairly lower compared to other cancers such as lung or colon cancer. It remains at 2 to 3% overall. So a lot of times prostate cancer goes undiagnosed because of its slow onset, and it usually starts off asymptomatic. Just to give you a little bit of anatomy, where the prostate is located, it's a gland that is part of the male reproductive system. If you can see my arrow right here, we have the bladder, and right below the bladder, we have the prostate. So anytime people have prostate issues, not just cancer, you can have hyperplasia, which is overgrowth of the prostate or enlargement of the prostate. That will cause compression of your urethra. So a lot of times people can present with symptoms such as difficulty with urinating, having blood in the urine, back pain. These are all symptoms that sometimes overlap with benign prostate hyperplasia, aka just enlargement of the prostate, but they can also present with, they can also be seen in prostate cancer. So in 2025 alone, the new diagnosis of prostate cancer remains at about 313,000, which makes up 30% of the cancers in the US. This is in males and females, breast cancer remains the highest. So, what should one look out for if you are concerned about prostate cancer? So, like I said, it's a slow onset and a lot of times goes undiagnosed because it remains asymptomatic. But sometimes it can present with frequent painful urination, interrupted urine stream. So, when a person is urinating, they will see a lot of pauses while they're urinating. So, not having a constant stream, blood in urine or semen. Like I mentioned, this oftentimes overlaps with prostatitis or enlarged prostate. But good thing is here at the Freehold Family Health Center, we not only take care of your screening, but we also can treat you for these conditions, including blood tests or antibiotics, and further referral to a urologist if deemed necessary. A lot of times, patients, when at the time of diagnosis, are usually um, already at a further stage of prostate cancer and may present with metastasis. So where can this spread? It can spread to your bones. So a lot of times patients will complain of back pain. That is the most common symptom of metastatic disease. A lot of just vague symptoms like fatigue, loss of appetite, eventually leading to weight loss. And because you have bone pain and bone loss, a lot of times people will also present with recurrent fractures. So, what are the screening recommendations? So, here at the Freehold Family Health Center, we do perform a detailed history to see what your risk factors are. Some of the risk factors that are modifiable, which means that you are in control and you are able to change these, are chemicals, diet. So diet in high fat, high cholesterol are all risk factors. And your exposure to chemicals. These are some things that we are in control of and are able to modify. Some of the non-modifiable risk factors are aging. So any male who's over the age of 50 has a known family history of prostate cancer, either in their dad, their sibling, or distant relatives are at an elevated risk for cancer. Certain geographical locations, such as Europe and US, people here remain at an elevated risk for getting diagnosed with prostate cancer. Genetics, again, plays a role. So how does one get screened for prostate cancer? So one of the most common and easy techniques is digital rectal exams. However, this is not very reliable in terms of diagnosing someone with prostate cancer. A lot of times, anyone who has enlarged prostate will have abnormalities on the digital rectal exam. We do have a blood test called the prostate-specific antigen. So this is an enzyme that is produced by the prostate itself. So American Cancer Society does say that a PSA level less than 2.5 does not indicate frequent screening, but anywhere above 2.5 suggests yearly screening for prostate cancer. So who is at risk and who should get screened? So an average male who has no risk factors or no comorbid conditions should start discussing with their physicians as to when they or if they need to get started with cancer screening. So ideally, it is started at age 50. We do shared decision making with our patients to see if they really qualify for yearly or every 2 years or no cancer screening. So like I mentioned, we do the digital rectal exam and the PSA blood test. And anytime if it's less than 2.5, you screen them every 2 years. And if it's 2.5 and above, you screen them annually. Now, who is considered high risk? African American males, prior family history of prostate cancer, that is first degree, that is your parent or your sibling. Those people are considered as high risk individuals. And at that point, screening is started at 45 years and above. So the test and the exam remains the same. So we do the PSA test and with or without the digital rectal exam. And higher risk, multiple individuals in your family who are diagnosed with prostate cancer, earlier screening is recommended starting at age 40. So that was prostate cancer in a nutshell. Next, we're going to move on to ovarian cancer. So what are ovaries? Ovaries are basically organs of the female reproductive system that are essential in a woman's menstrual health and also determines the ability to get pregnant. The ovaries do produce something called an ovum that helps in one getting pregnant, and also produces hormones such as estrogen and progesterone, which are important hormones in a woman's menstrual health. There are about 20,980 new diagnoses of ovarian cancer, and 1 in 90 women are diagnosed with ovarian cancer. The deaths from ovarian cancer is very high compared to other cancers, only because by the time an individual female is diagnosed with ovarian cancer, they are already at stage 3 or stage 4. So about 12,730 deaths annually. Again, ovarian cancer is very similar to prostate cancer in terms of onset of symptoms. It's very dull, very vague, and which is why it is often missed and diagnosed at a much later stage. So what are the screening guidelines? Unfortunately, there are no screening tests available for ovarian cancer. So a lot of times physicians will rely on patients' individual history, family history, and signs and symptoms. So what are the signs and symptoms that can commonly be presented for someone who is at a higher risk for getting ovarian cancer? Abdominal bloating, feeling full, fatigue, having just vague abdominal symptoms such as nausea, vomiting, diarrhea, constipation, sometimes having all of these or not having all of these are also very common. Frequent urination, abdominal distension, having a pelvic mass, menstrual irregularities, or if you are postmenopausal, which means not getting your period anymore after usually the age of 50, if you start to notice bleeding, this is again a risk factor for having ovarian cancer. So what can we do to screen somebody for ovarian cancer? Like I mentioned, there are no specific screening tests. Physicians usually rely on family history and an individual history. So we can do pelvic exams, we can do abdominal exams to assess for any irregularities. Sometimes on a pelvic exam, patients will present with pelvic pain. If there is abdominal distension, there might be a mass that can be felt when we are examining the abdomen. Another test that is usually performed for someone who is at a high risk is called a CA-125. That is similar to PSA. This is a common blood test. This is not performed in every individual. Again, we do weigh risks and benefits on who needs to get this test performed. Like I mentioned, a very common way of testing someone or screening someone who is at a higher risk is through symptom education and genetic counseling and testing for those who are elevated risk. So who is at an elevated risk? So family history of ovarian cancer, breast cancer, colon cancer puts an individual at a higher risk. A genetic mutation called BRCA1 or BRCA2, family history of that definitely puts an individual at a much higher risk of having ovarian cancer. Now, there are certain tests that are performed like a pap smear. Pap smears do not test you for ovarian cancer, but it's for cervical cancer. So please do not mix up these two conditions. Pap smear is specifically for HPV infections and cervical cancer. So what can we do to screen somebody who comes from a high-risk population? We can do a vaginal ultrasound and, like I mentioned, the CA-125. This is done every 6 to 12 months. It can begin as early as 30 to 35 years, but it does have limited efficacy in terms of prognosis. Genetic counseling and testing. If an individual has a known history of breast cancer, ovarian cancer, colon cancer, we do refer patients to genetic counseling. That's where they can get tested for BRCA1, BRCA2, or Lynch mutations. These are all very commonly found in breast cancer, ovarian cancer, and sometimes uterine cancer as well. a very common procedure called a risk-reducing bilateral salpingo oophorectomy. So in layman's term, this is just a surgical removal of your ovaries and your fallopian tubes. So this is a preventative procedure. It does not cure ovarian cancer. This is done in high-risk populations who are positive for BRCA1, BRCA2, or even carriers of these genes. So like I mentioned, again, this is not a curative surgical procedure for someone who is already diagnosed, but is a preventative procedure. So this reduces the risk by 90% to progress into ovarian cancer. So what should one look out for? Like I mentioned, bloating, menstrual irregularities, vague abdominal symptoms such as constipation or diarrhea, weight gain, enlarging abdomen. So a lot of times women will come to you and say, I don't understand, I'm not eating unhealthy, my abdomen just seems to be getting bigger. So that is a red flag symptom and that warrants further testing. Like I mentioned, ovarian cancer has a poor survival rate. At the time of diagnosis, women are usually at stage 3 or stage 4. And at that point, there is only a 5-year survival risk. So what can you do to reduce your risk of getting ovarian cancer? So pregnancy is a preventative, or not preventative, it definitely reduces your risk of ovarian cancer. Breastfeeding, use of oral contraceptives. So these are things that you can control along with dietary modifications and lifestyle modifications. For both prostate and ovarian cancer, or just any cancer in general, smoking and alcohol play a huge role in someone getting any kinds of cancer, colon cancer, lung cancer, breast cancer, ovarian, colon cancer, and prostate cancer as well. So these are some modifications we can make that are within our control to reduce our risk for any cancer, not just prostate or ovarian. So like I said, increased risk factors include family history of ovarian, uterine, breast, or colon cancer, BRCA mutations, postmenopausal women who have abnormal uterine bleeding, and increased age after the age of 40 puts a female at an elevated risk for getting ovarian cancer. So what can you do to help treat both ovarian or prostate cancer? So a lot of times physician will just recommend watching and observing depending on what stage you're at. So if you're at an early stage, we just watch you, we monitor you, we do perform PSA levels, like I mentioned, every year, or CA 125 for those who are at an elevated risk. There's hormonal therapy, radiation, chemotherapy, surgical resection, and palliative care. But at the Freehold Family Health Center or at the VNA at any one of the locations, we do provide screening services. We talk about prevention, monitoring, surveillance, and if necessary, we do refer you to a gynecologist or urologist or an oncologist if you have reached a point where you need specialized care. For those who are beyond any of the treatments above, like radiation or chemotherapy, there's options like surgical resection, and those who do not qualify for any of these can undergo palliative care. So what palliative care is basically giving you relief from pain or symptoms, but it does not just reduce your prognosis of any of the cancers that we talked about today. Okay, so these are the locations where the VNA is present. Like I mentioned, it's in Asbury Park, Keyport, Red Bank, and Freehold Family Health Center here. I have the contact information. We are also having a vaccine drive on the 27th of September, along with a vegetable market. So bring your friends and family, make sure you get your flu shots. Flu season has started from September all the way through April. So make sure you and your family ends up getting the flu shots. Thank you. And if you have any questions, we can move on to the Q&A.
Thank you, Dr. Loda. That was amazing. And I'm so thankful that you ended with the Vaccines and Veggies event. We've been collaborating with the CHC and SEED and some other local partners like Center State and the Health Department, Neighborhood Connections to Health, to do this since the inception of COVID. And it's been really a lovely experience to promote um, preventative health issues as well as cancer, right? So thank you for mentioning that. I will pause now and ask the group if they have any thoughts or questions that they may have for Dr. Loda before I ask the ones I wrote down. You can feel free to take yourself off mute if you prefer, or put your questions into the chat box.
Hi, this is Rachel. I don't have a question, more so a comment. I just want to say thank you for highlighting SEED. We do work very closely with the CHC. So thank you for highlighting our services and all that we do in this great partnership that we have.
Yeah. So a lot of times patients do come to our office just for SEED visits, which are very helpful for cancer screening and spreading awareness. We've been doing pap smears, colon cancer screening, providing mammograms to all of our patients, and make sure they're up to date with the current screening guidelines.
Dr. Loda, can you explain for some folks that might not be as familiar with SEED, like exactly how that process would work when you receive a referral or when you're working with the patient, so folks realize how easy it could be to access if needed?
So SEED is basically a program that is funded by the state. It's for cancer early detection and education. Anybody can qualify for SEED. You just have to come to our office and let them know that you want to get screened for any cancer, and our front desk will help you set up these appointments. And SEED visits can be done any number of times in a month or during the year.
Wonderful. Thank you. Raven, I don't know if you have anything else to add, if you wanted to, piggyback on there, but feel free.
I was going to just say yes. SEED covers breast, cervical, prostate, and colorectal only. So yes, she's correct, as they can come in and get a pap or a mammo script, or if it's for a male, colorectal and prostate screening within the same month or different visits. But yes, those are the 4 target cancers that we do cover in Monmouth and Ocean County. And if anyone is eligible, they can go through the CHC, or they can also reach out to SEED directly.
Excellent. Thank you, Raven.
I did want to quickly mention current guidelines for prostate cancer. Previously, societies recommended against screening for prostate cancer, but due to the fact that a lot of males are being diagnosed, the numbers are going up. We do recommend those who are at a higher risk for getting prostate cancer do get screened.
Okay, good to know. Thanks for adding that piece. Does anybody else have a question or a thought that you'd like to share?
I would say thank you, Dr. Loda, for all the information and for presenting thoroughly and concisely on the matter. Biggest thing is really getting it out there so that this way people can stay on top of their health and catch things before it becomes too late. So that's what we're all about. Primary care for all of our patients. Preventative medicine is really, really big, and so the sooner we can actually diagnose and detect any of these cancers, the better, and the more likelihood and quality of life our patients have.
Thanks, Dr. Abdel. I agree. My mom's a ovarian cancer survivor. We found it at stage 3 because there are no screening opportunities, unfortunately, like Dr. Loda said. But she's on top of her health. She's a great self-advocate. She works with her care teams, and that's the way. Yeah, that's the way to keep moving forward. I really was appreciative that you said, Dr. Loda, about the difference between the cervical detections and screenings versus, the fact that there is no screening for ovarian, but to draw attention to the fact that they are different. They come with different sets of risk factors, as well as treatment options, screening services, et cetera. All right, I'm gonna ask the other question that I had. So Dr. Loda, right now, Ocean Mammoth Health Alliance is working with some other like-minded partners on bringing primary care as well as oncology teams together. So this could be family medicine or typical PCPs, and we want to figure out how to bridge the gap and bring better communication between primary care teams and oncology teams or specialty care teams for cancer patients once they are, let's say, discharged from their cancer treatments. So as folks are ending their cancer treatments and they're going back into a cancer-free world with no treatment, they often run into, well, who am I calling for the common cold or a flu, or if I have a pain in my arm, or, I'm an ovarian cancer survivor and all of a sudden my gut seems distended. Am I calling my oncologist for this? Am I calling my primary care for this? And so would you be able to speak a little bit to some of those processes or maybe some strategies on how to improve coordination of care for, let's say, a family doc, a medicine doc, or primary care doc, as well as specialty care teams like oncology?
This was a great question. I'm glad you asked. So, a lot of times patients are confused as to where to go for what symptom. Luckily, we as family physicians do everything. Consider this as a one-stop shop for all of your healthcare needs, from common cold to viral issues, GI issues, stomach issues, or even cancer. After you're done with treatment, family docs are capable of treating or monitoring these conditions. A lot of times, patients who have beat cancer, completed chemotherapy, we are capable of surveillance. So, like I said, someone who was treated for prostate cancer, no longer on treatment, we are still able to routinely check their PSA levels. Someone who has breast cancer, who has fought breast cancer, we're still able to perform those mammograms. And it's not just post-cancer, it's not just your cancer-related treatment or surveillance, but if you do have other remnant symptoms from chemo itself, like nausea, vomiting, we are able to control those symptoms. But as far as family medicine goes, we did talk about vaccination services. Prevention is one of our key subjects. So by preventing, we do give vaccines, we perform screenings, we do treatment, and we do refer to further services if needed. And then the patients will come back to us if they think that their symptoms were answered and they need further services. And a lot of times we do communicate with the oncologist. So once a patient is seen by the oncologist, we do obtain records from them. So we have it on file. So when patients oftentimes come back for follow-up, we're able to go over those records and also discuss the findings with the patients itself.
Excellent. Thank you for that. And in some of the research that we're doing and communicating with some of our partners, some of the center state docs had offered the option of creating something like a transition of care meeting, let's say with oncology and with primary care as that's happening, so that the patient is able to know and understand some of the limitations on both ends, the primary and the oncology teams. So all this to say, thank you for that response. And if anybody here has an interest in this initiative where we're figuring out how to better coordinate care for patients being discharged from cancer treatment, if your interest is in the primary care side or the oncology side, we'd love to have a conversation with you about how to try to, improve systems just generally, not of course, not singling out the VNA CHCs, but just generally speaking in the community of healthcare.
So as primary physicians, we are very big on continuity of care. So a lot of times, I also work at Central States. A lot of times our clinic patients do end up in the hospital. We have a team-based approach. So there's a lot of cancer patients. We do communicate with the oncologist. We're all on the same page about treatment. So when patients are discharged from the hospital and they need follow-ups with our clinic, a lot of times I will see the patient in the hospital and our office as well. So I'm in the loop about what the treatment recommendation was and how to move forward.
Yes, that's incredible. And making sure that the patient is informed and understanding too is so helpful. Yes, thank you for that. All right, so those were my questions, and my little blip there. Does anybody else have a question before I wrap up and give some updates? Hearing none, let me check the chat box one last time. Okay, seeing no questions or comments in the chat, I just want to thank everybody else for their thoughts today and for joining. Dr. Loda, thank you for this wonderful information session. We're going to do our next Health to Hold session on Wednesday, October 22nd. We'll be covering breast cancer, and the RWJ Barnes Health team will be helping us to spread that message and talking to us about the services that they offer. We are also going to be partnering with the VNA CHCs to paint the clinic sites pink for October. We're working with the outreach team, Neelam and her crew, to not only paint it pink and raise awareness, but we'll have lots of seat information present. We'll have lots of educational material out in the waiting rooms so that folks know the importance of early detection and screening. So more information on that. And if there are any other local partners, traditional health care centers or non-traditional partners. We've done this at banks before. So if you're interested in painting your site pink, please get in touch with me. We can make arrangements to do that. We have some of the decor already here at the office. So would love to raise awareness together if we can. And finally, the last update that I have is that the VNA's virtual platforms have changed. We are transitioning from Zoom to Microsoft Teams. So the next session on October 22nd that I mentioned with RWJ Barnabas will be a Teams meeting. I want to just highlight that because I know typically it's a Zoom link that you all receive from me. And I don't want there to be any confusion when you say, oh, wait a second, I'm now seeing Teams. Is this right? So yes, October and moving forward, all OMHA things will be scheduled via Teams. So please look out for more updates for those new links that you will be receiving. And that concludes all the updates that I have. And again, I'd just like to thank everybody for participating today. And thank you to Dr. Loda for doing this with us again. We really appreciate it. All right, everybody, have a great day. And thank you so much. Take good care.